Dr. Cheung and I, we do treat pancreatic cancers. I think we're going to bring up some topics, but we do want people to ask questions, and anything that you have on the top of your head, please bring forward. Dr. Cheung and I will flip between different topics between him and I'll just kind of control the screen. So I thought the first thing we should talk about is what are the statistics when we're talking about pancreatic cancer, because there's a lot out there. We know that unfortunately, even though we've made a lot of great strides when it comes to cancer treatment, we haven't really made huge strides for pancreatic cancer. So this graph looks at how survival changed in the US when you look back in the 70s. So the pink dot here is from 1970 to 77, whereas the blue dot is 2007 to 2013. So we're talking about a 30 years of time span. And you can see when you look at all cancers, we've seen a 17% improvement in survival. And things like melanoma, breast, kidney cancers, we've seen remarkable changes in survival. But unfortunately, pancreatic cancer is way down at the bottom. And that even though we're talking in the 30-year period, we have seen some improvement, but it's only about a 6% improvement. And so we're still less than 10% chance of surviving 5 years with the disease, which is really depressing statistics when we talk about it. When you look at cancer-related deaths projections in 2030, unfortunately, pancreatic cancer is going to be the second leading cause of cancer-related deaths if the projections hold true, lung cancer being the first. So pancreas is going to overtake colorectal cancer, liver cancer, breast cancer, because of the lethality of the disease, unfortunately. There was a study that was done by the International Cancer Benchmarking Partnership that was published last year, and it involved Canada, Australia, Denmark, Ireland, New Zealand, Norway, Sweden, and the UK. And what they did is they shared all their cancer statistics amongst each other. And just focusing on pancreatic cancer, when you compare to all these countries, net 1 year survival, so chances of living 1 year with any stage pancreatic cancer is between 25 to 40% chance. And then when you look in orange, which is the 5-year survival, we're talking less than 15%. And all the countries are ballpark the same time, the same amount. Though Australia seems to be doing a little bit better than the rest of the countries that are involved. And unfortunately, when you look at my province, Nova Scotia, it's doing the worst. So not something we like to share, but it's statistics. And so unfortunately, survival for pancreatic cancer is low. Just wondering if anyone has any questions so far. We'll stop every time.
Maybe just to provide a bit more information, I know that a lot of participants are from Canada. So my group recently looked at the number of new cases of pancreatic cancer in Canada each year. And I would say annually, it's about 5,000 new cases. And what's really interesting, which really underscores what Ravi mentioned, is that each year, the number of deaths from pancreatic cancer is about 4,800. So the fact that the number of new cases and number of deaths are very close together really brings home the point that survival from this disease is very poor. And we're always looking for new ways to treat pancreatic cancer to hopefully improve the outcomes. This is a pretty broad topic, and I think many patients and caregivers often ask me in clinic once they already have pancreatic cancer, can the pancreatic cancer could it have been diagnosed a lot earlier? And unfortunately, because the symptoms of pancreatic cancer are oftentimes very vague and non-specific, I would say early diagnosis has been very challenging. Many of the common symptoms that people present with are, again, just very general. So things like decreased appetite, weight loss, general fatigue, in retrospect, are some of the things that patients report when they think back to when they first had symptoms. Once they do reach a physician or a clinic, I'll just ask Ravi to move on to the next slide. We do a number of different investigations to look at whether there's truly a pancreatic cancer. So I already mentioned the importance of getting information about symptoms and doing a physical examination. But to confirm the diagnosis, we do a series of laboratory as well as imaging investigations. So for laboratory investigations, we've listed a number of tests that we would order. So CBC stands for a complete blood cell count. So we look at things like hemoglobin, which might be decreased because a cancer patient might have anemia. If the pancreatic cancer is more advanced, then can cause blockages around the liver area. We can also see abnormalities in something called bilirubin. And likewise, it can also cause liver dysfunction at advanced stages. So we look for, we check for LFTs or liver function tests. INR looks at a person's bleeding risk, which can also be affected. And interestingly, because the pancreas has many functions, in some patients, it can also affect glucose control. So any patient with a new diagnosis of diabetes, especially if they're older, would sometimes prompt us to investigate for whether or not pancreatic cancer is the cause. Once that's done, we also do imaging studies, so either in the form of an ultrasound or a CT scan. And again, I won't get into details, but there are specific things that we have to order to ensure that the imaging studies are hopefully informative when we do the CT scan. Another special blood test that we do is a tumor marker. So the one for pancreatic cancer is called CA19-9. It is helpful if it's elevated, but I would say that there are some cases where there is pancreatic cancer and the tumor marker is not elevated. So that's one of the caveats when interpreting the results. Nothing in medicine, and likewise in this case, nothing is absolute. So we really have to rely on 1 to 5 to help us decide whether someone has the disease or not. And then, because it is related to diagnosis, I will talk really briefly about the need for a biopsy. So a biopsy refers to sampling the pancreas and getting a tissue sample and having one of our colleagues, a pathologist, look at the sample to see whether it is cancer and also what type of cancer. So we get asked this a lot, either from patients or families, but also other colleagues, because sometimes based on history and lab tests and imaging, it does look pretty convincing that it is pancreas cancer. But as a medical oncologist, I'm sure Ravi is the same, we would still ask specifically, I know it is very suggestive of pancreatic cancer, but we still need tissue. And in the next slide, I'll talk about why that's really important. Tissue is the issue. I use that phrase as well with many medical students and trainees. And that's because there is a small possibility that the imaging in lab will still be abnormal, but it's actually not the pancreatic cancer that we're talking about. There are other cancers in the pancreas that are a lot less frequent and are actually treated very differently. So there's something called lymphoma, which can also appear in the pancreas. There are also something called neuroendocrine tumors that can appear in the pancreas. And what's interesting is that in rare cases, other tumors from, the skin or ovaries or the colon can actually metastasize to the pancreas and looks the same in the pancreas. So the purpose of a biopsy is to get a tissue, and only a pathologist can, under microscope, determine whether it is the more common pancreas cancer that we're talking about today. So again, I have to really underscore that a biopsy is really important, and sometimes, because the pancreas is a deep organ, it can take a couple attempts, if not more, before a biopsy is done sufficiently to get us enough tissue for the pathologist to confirm the condition.
One of the things is they would need to know what type of cancer this is, if it is cancer in the first place. If it is cancer, need to know what it is important, because you treat each type of cancer differently. So lymphoma would have a different regimen, chemotherapy regimen or chemotherapy drugs, than a pancreatic cancer, than a neuroendocrine tumor, than a cancer that is from somewhere else to the pancreas. So they would need to actually really firm down the diagnosis. So starting chemotherapy now without a diagnosis, a firm diagnosis, there's potential that you're treating something incorrectly, or using drugs that aren't going to be as active on that disease.
Yeah, I would completely agree, and I know sometimes a 3-week wait is very long. In Alberta, it's anywhere between 2 to 4 weeks, so I think it is very similar to what you're describing. But as Ravi mentioned, it's really important to ensure we have the right diagnosis before jumping in with chemotherapy, which can work, but also has toxicity. So I think there is some risk to sort of prematurely assume. And again, sometimes we're incorrect, meaning that we think it's pancreatic cancer, but it's something else completely. And in rare cases, it's not even cancer.
Maybe we'll move to the next topic about how do we treat pancreatic cancer. And so, just this one. So right now, when we talk about potential treatment options, usually we involve people like the surgeons, interventionalists, radiologists, pathologists, as they're all part and parcel of the treatment for pancreatic cancer. The surgeons, the radiologists will take a look at the lesion and try to determine, is it something they can take out, and can they do a surgical interventions like a pancreatectomy or a Whipple's procedure, which is a large procedure. No, they're both large procedures, actually, taking out part of the pancreas, the whole pancreas, part of the GI tract, maybe taking out the spleen as well. In some situations, we may give chemotherapy, sometimes chemo plus radiation. Sometimes we may need to stent, and stenting occurs when the cancer is very close to the bile ducts and it causes blockages of the bile duct. And the bile duct is important to allow the bile, which is produced by the gallbladder, as well as what is being excreted from the liver, into the GI tract. When it starts to block up, everything kind of backflows into the liver and then into your bloodstream as well, causing some of the symptoms. And so we use things like stenting, which is really just a slinky being put into the biliary tract to open things up. Sometimes clinical trials are options for cancer patients, and then sometimes, if none of the above is applicable or the patient doesn't want to go through any of those things, supportive care is another option as well. So when we talk about chemotherapy, as both Dr. Cheung and I are medical oncologists, and this is kind of what we do, you'll hear things like neoadjuvant, adjuvant, and palliative treatments. And so just to kind of give people a framework of what we're talking about here, when we say neoadjuvant chemotherapy, the goal of that chemo is to try to shrink the tumor to make it more amenable for surgery. So a lot of times the cancer may be very close or around some of the blood vessels, making it a lot more difficult for the hepatobiliary surgeons to try to take it out. So sometimes we might try to give chemo to try to shrink the cancer away from the blood vessel to allow it to go for surgery. Sometimes after surgery, we'll give chemotherapy, and we call that the adjuvant setting, so after surgery. And the goal there is try to reduce the risk of this cancer that's been taken out already by surgery from returning. So kind of almost like an insurance policy to try to reduce the chance of this cancer coming back. And then the last you may hear is palliative chemotherapy. There, the goal of the chemotherapy is to improve the quality of life of people, as well as to improve longevity as well. When we look at the different drugs, you can see here there are several different chemotherapy regimens used, but they're used both in the palliative setting, sometimes the adjuvant setting, as well as neoadjuvant setting as well. So there's only so many different drugs available for pancreatic cancer, and these are drugs where there have been clinical trials that have shown that they have activity in pancreatic cancer.
I think I'll touch upon the side effects and also how you as a potential caregiver can support the patient. This way, I think Ravi can speak more about the precision medicine, which he's more involved in. There are a number of potential side effects associated with chemotherapy, and I know this often causes lots of concerns for patients and families. So I will go over a myriad of things that can happen, but I'll also hopefully end on a more positive note that usually most people don't get all of this. So I'll go through like the battery of things that can be caused by chemotherapy. So there could be nausea, vomiting, and diarrhea. But again, the good thing is that there are medications we can give to hopefully prevent or reduce the risk of these symptoms happening. Fatigue, hair loss, mouth sores can also occur. I would say complete alopecia or complete hair loss is uncommon with the pancreatic cancer regimens, but there could be hair thinning during treatment. Depending on the regimen that we're giving the patient, there can also be muscle aches or joint pain. There is a medical term called neuropathy, and that's just a fancy word for numbness and tingling of the hands and feet that can occur. So I already mentioned, I think a few slides before about weight loss and decreased appetite. Studies have also emerged showing that people can get chemo fog or chemo brain when they're on chemotherapy. So this refers to just not thinking as clearly as usual, having a harder time remembering things. And then most importantly, chemotherapy targets rapidly dividing cells. So this includes cells, in the bone marrow that is in charge of building up your immune system. So once chemotherapy starts in a patient, they're at a higher risk of infections. So next slide. So there's more. I know, again, hopefully this is not overwhelming. Some chemotherapy can also cause a loss of libido, some infertility issues. I guess because the vast majority of patients are diagnosed with pancreatic cancer in the older age group, the infertility concerns are luckily not as high priority given the age. And other things that can happen are increased bruising, increased risk of blood clots. I already mentioned the risk of infections going up as well. And then a couple other minor things are nail changes in dry hands. This is not dangerous per se, but it is a bit of a nuisance that are reported to me as a physician often. And with chemotherapy, they can also be dehydration. So I do ask patients to hydrate frequently and also drinking plenty of fluids. Next slide. So again, many potential side effects, and it does worry patients understandably. But the next slide I think is an important one. which really, I think, highlights the fact that, next slide. Yeah, so this slide is important because we progress to the next slide as well. So this really showcases a lot of the side effects are listed when you read the back of a aspirin bottle or the box of an aspirin medication. They list a lot of things that can happen. So I would say chemotherapy is also in the same boat. There are a lot of potential things that can happen. But when I go through my clinic or my patient list, I would say the vast majority of patients do not get all the side effects I just mentioned. They might get a few. I always say this before a patient leaves my clinic room, just because I don't want them to leave the hospital or clinic being very worried. And over time, we're getting very good at managing side effects. So the hope for most patients is that they might get a few, but not all of the side effects. Next slide. Yeah, so I'll touch upon this part quickly because it relates to the side effects part. So family members and caregivers are often wondering, how they can support someone on chemotherapy. So the next slide will summarize some of the things you can do. Not all of them are chemotherapy side effect related, but there are other things that you can do to, I think, help your family member or friend. So next slide. So again, make sure they hydrate well. And I think above and beyond the side effect part, I think psychologically, anybody on chemotherapy, it is very taxing. And the last thing they sometimes want to think about is, what should they eat, and how do they prepare, breakfast, lunch, and dinner. So I see many friends and family members also helping with meal preparation. Helping the patients keep active as much as possible. Again, not to overdo it, but I think staying physically active during treatment, if possible, is a good thing. Many family members also accompany their friend or patient to the clinic. In the COVID pandemic, it's been a little trickier because we're limiting visitors in hospital, but once the pandemic's over, I find that many patients really benefit from having someone else there in clinic, just because oftentimes we go over a lot of information and not all of it's retained. So having someone there and having another set of ears, I think is very supportive and very important. And finally, aside from chemotherapy, we do give a lot of medications to combat the side effects. It is, again, a lot to kind of go through. So any reminders that you can do to help the patient remember to take all these supportive care medications would also go a long way. So those are the things that I think many patients find beneficial and worthwhile. I mean, I don't have I think a short or sort of magical solution to that, just because the underlying cancer and the chemotherapy can affect appetite. What I have noticed though, and this might be helpful, is that once a patient has a new cancer diagnosis, it is not uncommon for me to hear that many of them alter their diet significantly. So they would, I hear sometimes they would avoid meat completely, or they become a vegetarian, or they just really alter things very drastically. So I do sometimes hear that and wonder how much that is contributing to the lack of appetite. So I would say during chemotherapy is probably not the best time to make dramatic changes in someone's diet pattern. So that's that I've noticed has helped a lot of patients. But short of that, I don't have like a magic bullet in terms of fixing that. To an earlier point, I do engage the nutritional and dietitian team quite a bit, and sometimes they have recommendations as well. Again, I'll look to Ravi to see whether he has any additional suggestions.
Yeah, sometimes I find small meals more often seems to work better, because if people who sit down with a large meal, they won't eat as much, they'll feel full, and and sometimes they have problems with digesting. So smaller meals, they're able to digest more, and they can take more in. you know, sometimes I find there's some people who drink a lot of water, which is good. Hydration is really good, but it also can fill you too. And so it's kind of balancing the need to eat, but also to maintain hydration too. And I agree with Winson as well. I do see a lot of patients that once they've had a diagnosis, they've now altered their diet to something different. I usually tell patients, if there's something you like to eat, just eat it. And sometimes that works as well. And sometimes they think about trying to cut out something because with their diagnosis, and they go, no, I mean, everything in moderation is fine. Okay, maybe I'll just move to the next topic. It was something we wanted to talk about was precision medicine, because it's something that you'll hear about if you do kind of reading on the blogs or in the forums. And it's also in some of the guidelines in the United States and for some of the pancreatic cancer treatment. So the idea of precision medicine is cancers, they have genetic changes, and the idea is, can you find what genetic change is occurring in that cancer patient's tumor and identify, is there a drug that can be used for that genetic change to then treat that patient and then to monitor their treatment and the response. Without precision medicine, the idea is what we do now is you have a patient and you give everyone the same treatment. Some patients are going to benefit from that treatment. Others are not going to have any benefit from that treatment, and the others will have adverse events from that treatment, will get side effects and bad outcomes. The idea with precision medicine is then to kind of tailor that treatment to each individual patient. So they're getting very specific treatments to each individual person to have a benefit and lessen the no benefits or adverse events that may happen. So this has been going on for about 3 years, I think. And this is in the US, as I mentioned, it's in the guidelines, and the Pancreatic Cancer Action Network, or PanCAN, has been running a study called Know Your Tumor, where they liaise with a couple for-profit companies and have done genomic testing on pancreatic cancer, and then kept the data and analyzed it. And what they found was about a quarter of the patients had what we call highly actionable mutations, i.e. there was some kind of drug that could be used for that patient because of the mutations in their tumor. Another quarter had drugs that had actual mutations, but weren't really any matched therapies for. And the other 50% really didn't have anything that was actionable, i.e. there wasn't a mutation that they could find with a drug that they could utilize. And very, very recently, they had published some of their survival data. And what they found was patients who had no real actionable mutation, the average survival was about 1.3 years. And then those patients that had mutations but didn't really have any matched drugs for those mutations lived about the same, 1.5 years. But those that could get on some kind of tailored treatment for that mutation actually lived almost double survival, showing that, you know, if you can find mutations with drugs targeting them, they actually do better. Now, you know, in Canada, unfortunately, while it may be in the guidelines for the US, in Canada, it's only research-based. And so if patients want to access precision medicine, which is what we called next generation sequencing, they do have to pay for it out of pocket. And some of the companies that do it for pancreatic cancer, Tempus and Perthera, are two companies in the US. And Foundation One is also in the US, but they have a head office in Toronto. All three will do precision medicine, but I mean, the cost is definitely not cheap. It's over $5,000 US to do this. Sorry, one other issue with this is, so say you do find a mutation that is targetable and there's a drug out there, then at least in Canada, there is the question of how do you access that drug? there's really only 4 ways to access this drug, because usually those drugs aren't Health Canada approved to be used for that situation in pancreatic cancer because it's never been tested in a clinical trial. So the only ways is if a drug company that's producing that drug is able to provide compassionate access for that drug. And reality is, I think I've only seen approvals at about 5%. So it's very, very low that I see pharmaceutical companies approving compassionate access for these drugs. The second, if you have a Cadillac insurance company that goes ahead and approves it, and I've not seen that yet, but I've heard stories that there are some. Third, if you can find a clinical trial that has your cancer with your mutation, which has that drug that can be enrolling the patients. But those are far between in Canada right now. And the fourth is if the patient pays for the drug out of pocket, which is definitely not a cheap option as well.
Do you see this as something that is going to change in Canada, or
eventually? I think it's where cancer treatment is going. It's just that right now it's getting enough research to back it up. The way drugs are funded in Canada right now is usually there's a clinical trial that shows that a drug works in a particular disease site, and then it gets submitted to Health Canada and goes through all the different committees before it gets approved and funded in each province. Precision medicine is a different entity because you're looking at a particular mutation, and so you usually don't have the clinical trial data to submit to Health Canada for approval. And so a lot of drugs now, as opposed to submitting a drug for a particular cancer, you're now submitting a drug for a particular mutation, which is a little different, and it's something that's going to need to be changed in the future, as Health Canada will have to wrap head around how to fund these drugs as well. And so I think it is going to come, but there needs to be more data before Health Canada is going to approve it in the public system. I don't know, Winson, if you have anything else to comment on what's it like in Alberta?
I think it's very much the same. I don't think it's standard. You know, oftentimes when someone's interested in precision medicine, we'll do our best to see if there's a trial available. But I do think we're heading that direction. But I still think the standard is the conventional chemotherapy that you just described a while ago, just because that's still more proven, and that's still what the vast majority of patients are getting.
We all go ahead, and so I always field questions about, are there centers of excellence for pancreatic cancer, like places where they see a high volume of pancreatic cancer, and there is. So Pancreatic Cancer Canada has highlighted several institutions in Canada that do see a fair amount of pancreatic cancer. So in BC, there's the Pancreas Centre BC, there's the Tom Baker Cancer Centre in Alberta, which Dr. Cheung is involved with. In Ontario, there's the Wallace McCain Centre at Princess Margaret Hospital for pancreatic cancer. Kingston General Hospital also sees a fair amount of pancreatic cancer, as well as the Ottawa Integration Cancer Centre. In Quebec, McGill sees a fair amount of pancreatic cancer, and then Capital Health or Nova Scotia see a fair amount of pancreatic cancer as well. And so Pancreatic Cancer Canada has highlighted these institutions as what they call their centers of excellence for pancreatic cancer. And so one of the reasons why they were called Center of Excellences was because they're institutions that see a high volume pancreatic cancer. They tend to have specialists like hepatobiliary surgeons that are focused there, that do see a lot of surgical options for pancreatic cancer. And a lot of these institutions also do a lot of research in pancreatic cancer, and so may be more on the cutting edge of what's out there. Now, that being said, chemotherapy is kind of standardized across the country. Standard care chemotherapy can be given at any institution as well. It's just these centers tend to see higher volumes, and primarily that's more important for surgical options for patients, because you want centers that have seen a fair amount of pancreatic lesions that can do what we call Whipple surgeries or pancreatectomies.
Yeah, I would agree with that. I think the chemotherapy that we can give right now is pretty standard. So whether you're at a larger center or smaller center, it's the same chemotherapy, similarly trained nurses and physicians. But again, for surgery, there's been studies showing that the more a surgeon does a certain surgery, the more effective that surgeon is at doing that surgery. So I think for surgical options, in certain scenarios, perhaps certain centers of higher volumes can lead to better outcomes. But again, in Ravi and my line of work, the chemotherapy options is pretty consistent across the board. All right. Yeah. So I'm cognizant of the time, so I won't spend too much time on the last couple of slides. We're nearing the end. But I think we do want to touch briefly on, a family's risk of getting pancreatic cancer. I think earlier I heard one of the participants mention that there's a family history, and once someone has pancreatic cancer, I think the concern is that other relatives would also be at higher risk of getting it as well. So next slide. So I think in the context of a bad situation, I think the reassuring thing to glean from this slide is that the vast majority of pancreatic cancer is what we call sporadic, meaning that it happens by chance. And just because one family member has it does not necessarily mean that you are at a higher risk of getting it. Having said that, there are exceptions. I would say 10 to 20% of pancreatic cancer are what we call hereditary or familial. So hereditary means that there's actually a known gene that is associated with pancreatic cancer development. And by that sort of nature or sort of assumption, this can be passed on to another family member. So usually parent to child, for example, or across siblings. Familial cancer is a related concept, but not exactly the same. It means that there is a family history of pancreatic cancer, but it could be due to genetic factors or environmental factors, and really is not known. We just know that there's a few family members who have it, but there's no isolated gene or isolated factor that's responsible. So again, I want to remind patients and families that the vast majority are sporadic. So there's no known genetic link there. And then the final slide, I'll end with this. We also get asked frequently whether there are risk factors that increase someone's risk of getting it. So these are environmental factors, so things that you eat or drink or do in your daily life. So again, there's not many factors of this nature except smoking, high alcohol consumption, I would say a poor diet. Those are known to elevate a person's risk a little bit. But other things such as physical activity or coffee consumption, those are a lot less clear. I know in the lay media, there seems to be lots of emphasis on these factors. So I think at the end of the day, there's very few and far between things that you can do to elevate your risk. But common things being common, things like smoking, high alcohol consumption, and poor diet, not only increases your pancreatic cancer risk, but all cancer risk. So I think the take-home message there is to avoid smoking. I think social alcohol use is reasonable, but I think excessive use is not recommended. And again, definitely abide by a healthy diet that's rich in fruits and veggies.